Hello everyone, welcome to my class. Let's discuss about nerve injury from anatomy to restoration. A comprehensive journey through peripheral nerve structure, injury, classification, biological response, and the surgical strategies that restore function in case of nerve injury. Let's begin the journey. The architecture of peripheral nerve. The neuron components, cell body, axon, and the myelin sheath form the core conductive pathway for motor and sensory signals. Protective layers, three concentric sheaths, epineurium, perineurium, and endoneurium, shield and organize nerve fiber. Blood supply, vasa nervorum, provide microcirculation critical for sustaining the distal action and supporting regeneration. So basically, neuron components of a peripheral nerve is cell body, axon, and myelin sheath that form the core conductive pathway for motor and sensory signals. Protective layers of these components, three concentric sheaths from out to inside. More outer layer is epineurium, then perineurium and endoneurium. Shield and organize the nerve fibers in a nerve. Blood supply, the vasa nervorum provide the microcirculation critical for sustaining the distal action and supporting regeneration. Okay, let's see a picture. It's basically neuron anatomy. This projecting parts is called dendrite that's attached to another nerve. The central part, this is basically cell, the body of nerve. In central there is a nucleus, and this material is soma, and axons, this tail-like projection from the body is axons. Axons covered by myelin sheath, and myelin sheath containing the Schwann cell. In between that groove is called node of Ranvier. The current, that action potential jump from one node to another. That means through the axon, and this is axon terminal. This is basically nerve anatomy, microscopic, the single nerve cell and different parts. Okay, then let's see the covering, that protective covering of nerve. From if we go outside, the cross section of a nerve show the outermost layer epineurium, then perineurium. Perineurium is covered the some group of nerve fiber that's called nerve fascicle. This is nerve fascicle. Okay, a nerve fascicle is composed of multiple myelinated nerve fiber. This nerve fiber, individual nerve fiber, is covered by endoneurium. So basically, single nerve, myelinated nerve fiber covered by endoneurium. Some group of myelinated nerve fiber form the fascicle, and nerve fascicle covered by perineurium, and some nerve fascicle is collectively covered by epineurium, that's basically cross section of a nerve and shows the structures. Fascicle contain that unmyelinated and myelinated nerve fiber. Okay. So nerve fiber, axon, neuronal projection, nerve twin, nerve ending, fascicle nerve branch, nerve that are basically synonyms. Nerve trunk, peripheral nerve, nerve bundle. Okay. That's structure and synonyms. That's okay. These are the basic anatomy of nerve fiber. Okay, let's go. Classification, classifying the damage of a nerve. Uh, Shedon and Sunderland classification. Nerve injuries are graded by severity from transient conduction blocks to complete severance, guiding both prognosis and treatment strategy. From transient conduction block, basically there is no anatomical damage, only the physiological blockage of the nerve conduction. And the more severe, from partial to complete separation of nerve fiber, that complete severance. The grading of nerve injury is guiding both the prognosis and treatment strategies. Higher Sunderland grades indicate greater structural disruption and more complex path to recovery. Okay, grade 1, basically neuropraxia, first degree, temporary conduction block, spontaneous recovery expected, there is no structural damage. Axonotmesis, second to fourth degree, axon disrupted but sheath intact, require regeneration. Only the axon, up to the axon is damaged. Neurotmesis 3, that is fifth degree, complete nerve severance, required surgical repair. These are the basic grading of nerve injury. To guide to understand the recovery and the prognosis and the treatment strategy. Etiology: how injuries happen. Mechanical trauma, laceration, fracture, and crush injuries directly disrupt the nerve continuity and are the most common causes of peripheral nerve damage. Mechanical trauma is the most common cause of nerve injury. Iatrogenic factors, surgical procedures carry inherent risk. Retraction, transection, or thermal injury can inadvertently damage adjacent nerve. During any surgery, the iatrogenic damage to the nerve is also a causative factor of nerve injury, because during surgery the skin or structure cut. So when the incision is made by a doctor, by a surgeon, the local nerve also get injured. This is basically iatrogenic factors. Systemic triggers, metabolic diseases like diabetes, neurotoxins, that's chemicals that is bad for nerve, neurotoxins, and thermal trauma causes diffuse or focal nerve dysfunction without direct mechanical force. What diabetes actually do, there is a obliteration of that is microangiopathy that damage the blood supply of the nerve. So the nerve get damaged in long-standing diabetes. Neurotoxins like snake poison or other chemicals that also and the thermal trauma causes diffuse. That means diffuse, that is more area, or focal, some specific area nerve dysfunction without direct mechanical force. So these are the etiology how injury happen to a nerve. The biological clock, Wallerian degeneration, After injury, the distal axon undergoes a tightly regulated regenerative cascade, a prerequisite for successful regeneration. Phase 1, 0 to 24-hour axon fragments myelin breaks down. Phase 2, 1 to 7 days, Schwann cells proliferate, macrophages clear the debris. Phase 3, 15 to 30 days, axon budding starts, grows 1 millimeter per day. So these are the basic concept of Wahlerian degeneration. After injury, distal axons undergo tightly regulated regenerative cascade. So phase 1, phase 2, phase 3 of Wahlerian degeneration of nerve injury. In case of nerve injury, how nerve gets recovered. Clinical assessment and diagnostic. Physical examination, symptom mapping. Paresthesia, muscle atrophy and motor palsy localize the lesion. The area where the nerve damage occur, the sensation is decreased or partial or completely. The muscle, as a muscle denervated, so muscle function lost and muscle become atrophied. And motor palsy localizes the lesion. There is a loss of motor function also in the area that nerve damage, the supplied area. Provocative tests like Tinel, Fallon test and Darken signs confirm nerve irritation. Electrodiagnostic nerve conduction velocity, that is, measure signal speed and amplitude across the injury. So the more the injury, the less the signal will transfer, and they will catch the site and degree of nerve injury. Nerve conduction velocity, NCV study, is very common study. We advise for patient came with nerve injury, the symptom of nerve injury, that is weakness, numbness of some area. Then electromyography detect degeneration and reinnervation at the muscle level. Okay, the gold standard for grading severity, electromyograph. So these are the electrodiagnostic, NCV, nerve conduction study, EMG study. The golden rule of recovery, that is critical window 15 to 18 months. Motor end plates must be reinnervated before irreversible muscle atrophy sets in. So within that critical period of time, the motor end plates must be innervated, otherwise the muscle will atrophy irreversible. Muscle atrophy occur irreversibly. 1 millimeter per day regeneration rate, axon grows slowly. Proximal injuries may never reach distal target in time. So 1 millimeter per day regeneration rate, 0% avulsion repair. Root avulsion lack a distal stump. Physiological hurdles prevent direct repair. So root avulsion is very as this lack a distal stump, physiological hurdles, direct repair is very hard, become hard, as they don't have or lack of distal stump. Surgical delay is a single greatest modifiable factor in patient prognosis. Time lost is function lost. So more delay means less recovery, more damage. Timely intervention is absolutely necessary for better outcome in case of nerve injury. Surgical principles, primary and secondary repair. Direct neuropathy, epidural repair, simple less tension versus fascicular repair, more precise alignment of fiber group. Direct neuropathy, either epidural repair or more precise alignment of fiber group. Uh, that is fascicular repair. The single fascicle repair is connected rather than the epidural repair where the two ends are connected of a damaged nerve. Bridging the gap when tension-free repair is impossible. Autologous nerve graft, sural nerve, most commonly sural nerve, bridge the defect. So autologous nerve graft, when there is a more gap and the repair is not tension free, so nerve graft from most of the time from sural nerve bridge the defect. Modern advancement, biodegradable nerve conduit and trophic factor delivery systems reduce donor side morbidity and guide axonal growth. So that's very important. Beyond traditional repair, nerve transfer. Nerve transfer, a healthy expendable donor nerve is rerouted to reinnervate a paralyzed target, bypassing the injury zone entirely. So nerve transfer basically a healthy, the nerve is not damaged. Expendable donor nerve is rerouted to reinnervate a paralyzed target, bypassing the injury zone entirely. Tendon transfer. When nerve regeneration fails or timing is lost, tendon transfer mechanically restores the movement by redirecting functional muscle. So nerve transfer, a healthy nerve from one side is rerouted to reinnervate a paralyzed target to make the paralyzed area functional. But when the nerve damage is permanent, a healthy tendon also can be transferred to the damaged area to restore the function. Functional reanimation. Strategic combinations of nerve and tendon transfer can reanimate paralyzed muscle, restoring grip, pinch, and elbow flexion. So, functional reanimation, strategic combination of nerve and tendon transfer, that is a combination of both nerve and tendon transfer, can reanimate paralyzed muscle, restoring that even minor movement, fine movement. The future of nerve restoration. Emerging technologies like synthetic scaffold and nerve tubes guide axon regrowth without donor nerve harvest. Basically, neural tubes or synthetic scaffold and the neural tubes guide the axon regrowth. Basically, when there is a more gap, the scaffold or neural tubes basically guide the axon growth. So there is no need of nerve harvest or donor nerve to fill the gap. Trophic factor engineering accelerate regeneration speed and fidelity. Bioelectric transfer interfaces may one day bridge irreparable gaps. The unchanging principle, despite technological advantages, early detection and precise surgical timing remain the most powerful determinants of patient outcome. The biology of nerve regeneration sets the rules. Our rules is to act within them. Simple that. The early detection of nerve injury and precise surgical uh, timing remain the most powerful determinants of patient outcome. Thank you. I hope you get some idea about nerve injury types and what are the uh, treatment we can provide to the patient if they come with nerve injury. Thank you. Good night.